As you know, acute inflammation is never just a single isolated event. It is a highly complex, tightly regulated integration of vascular responses, cellular actions, and chemical mediators, all working in perfect synchronization to protect the body.
This chronological progression naturally follows the 5 R's of inflammation. It kicks off with recognition, where tissue-resident sentinel cells sense microbes or damage. Then comes recruitment, where vascular changes summon leukocytes and plasma proteins. That is followed by removal, as phagocytes ingest and destroy the offending agent. Next, regulation provides the chemical stop signals to terminate the response. And finally, resolution repairs the tissue and returns it to homeostasis.
Let's look closer at that first step, recognition. Microbial products, necrotic cells, or foreign bodies act as the immediate trigger. They bind directly to toll-like receptors on the surface of sentinel cells. This binding activates an internal complex called the inflammasome, which immediately produces interleukin-1. That chemical signal instantly recruits white blood cells and kicks off the wider inflammatory cascade.
Once triggered, the blood vessels change incredibly fast. From a normal state of central flow, histamine drives vasodilation, visibly widening the vessel. This is what causes local redness and heat. As fluid leaks out, the loss of liquid concentrates the red blood cells, which increases blood viscosity and slows down the flow. This slower flow naturally pushes the white blood cells toward the peripheral vessel wall, a process known as margination, positioning them perfectly to exit.
During this shift, very specific fluid dynamics are at play. A transudate is non-inflammatory. It happens from pressure imbalances, pushing fluid out while the vessel wall remains completely intact, resulting in low protein and very few cells. Conversely, an inflammatory exudate involves actual structural changes. The spaces between the endothelial cells widen, allowing a protein-rich fluid, packed with cellular debris and leukocytes, to escape right into the tissue.
Now, these vessel gaps form on specific timelines. There's an immediate transient response called endothelial contraction, which is triggered by histamine and leukotrienes. The cells rapidly contract to create gaps that last about 15 to 30 minutes. In contrast, severe burns or microbial toxins cause direct endothelial injury. This is a prolonged response where the cells are physically destroyed, causing leakage that lasts for hours or even days until it is repaired.
While that fluid escapes, leukocytes migrate from the bloodstream into the tissue. First up is margination and rolling, where selectants on the endothelium loosely bind to the leukocyte. Next is firm adhesion, where chemokines activate leukocyte integrins to bind tightly, completely stopping the cell. Third is transmigration, where the leukocytes literally squeezes through the interendothelial gaps. Finally, via chemotaxis, the cell navigates the extracellular matrix by following a strict chemical gradient directly to its target.
The timing of this cellular arrival is highly predictable. The immediate response is always fluid edema. This is rapidly followed by neutrophils, which are abundant and fast-acting, but they undergo apoptosis and die within days. As the neutrophils decline, macrophages arrive. They are slower to mobilize, but they survive much longer, ultimately becoming the primary cleanup mechanism in the days that follow. Upon reaching the target, intracellular destruction begins. First, microbes are coated with opsonins, allowing the cell membrane to zip around them and form a phagosome. Second, this phagosome merges with a lysosome. Third, in the resulting kill zone, a respiratory burst converts oxygen to hydrogen peroxide. Myeloperoxidase then converts that hydrogen peroxide into hypochlorite, while nitric oxide forms highly reactive peroxynitrite to completely obliterate the microbe.
But what happens when neutrophils are completely overwhelmed? They perform a programmed cell death to create neutrophil extracellular traps, or nets. The dying cell extrudes a viscous meshwork of its own DNA and histones embedded with antimicrobial proteins. This physically traps bacteria to prevent them from spreading. However, the exposed nuclear antigens from these nets are strongly implicated in triggering systemic autoimmune diseases, such as lupus.
All of these physical and cellular actions are directed by chemical mediators.
These mediators act on specific receptors, are tightly regulated, decay rapidly, and trigger massive cascading amplifications. They fall into two distinct categories. Cell-derived mediators are produced locally by tissue sentinels like macrophages. These can be preformed in granules like histamine or synthesized on demand. Plasma-derived mediators, on the other hand, are synthesized systemically in the liver and circulate in inactive precursor forms, requiring specific proteolytic cleavages to function.
The primary vasoactive amine is histamine, sourced predominantly from mast cells. Triggered by physical injury or allergic reactions, it causes immediate arteriolar dilation and venular permeability. Alongside it is serotonin, sourced from platelets and neuroendocrine cells. During inflammation, serotonin acts directly as a vasoconstrictor. Moving on to the arachidonic acid cascade, this is derived from cell membrane phospholipids. Phospholipase A2 converts them into arachidonic acid, and here the pathway splits. The cyclooxygenase pathway produces prostaglandins for vasodilation, pain, and fever. The 5-lipooxygenase pathway produces leukotrienes for chemotaxis and permeability. Importantly, these specific steps can be pharmacologically blocked. Corticosteroids inhibit the initial phospholipase, aspirin and NSAIDs block the cyclooxygenase pathway, and asthma drugs block leukotriene receptors. Cytokines exert both local control and systemic effects. Generated primarily by macrophages and dendritic cells, tumor necrosis factor and interleukin-1 activate the local endothelium to express selectins and promote fibroblast activation for repair. Systemically, they signal the brain to induce fever, the liver to produce acute phase proteins, and the bone marrow to stimulate white blood cell production. In severe infections, they can cause vascular dilation so extreme it results in clinical hypotension and shock.
Then we have the complement system, consisting of plasma proteins that circulate inactively until triggered by microbes. The crucial step here is the cleavage and activation of C3, which creates the three-pronged defense. First, C3a and C5a stimulate mast cells to release histamine for inflammation. Second, C3b coats the microbe as an opsonin for phagocytes to grab. Third, component C5b through C9 assemble into a membrane attack complex, punching a physical hole into the microbial lipid bilayer to cause osmotic death.
To summarize, specific chemical mediators are responsible for exact pathologic manifestations. Vasodilation is driven by histamine and prostaglandins. Vascular permeability is controlled by histamine, leukotrienes, complement components, and bradykinin. Chemotaxis relies on leukotrienes, TNF, interleukin-1, and complement. Fever is driven by prostaglandins and cytokines. Pain is triggered by prostaglandins and bradykinin. And finally, direct tissue damage is caused by lysosomal enzymes, reactive oxygen species, and nitric oxide.
These physiological changes present in very specific morphologic patterns clinically. Serous inflammation appears as a cell-pore fluid, typical in a skin blister. Fibrinous inflammation occurs with more severe injury, allowing fibrinogen to leak and form a dense meshwork in body cavities. Purulent inflammation produces pus, an exudate rich in neutrophils and necrotic debris, typically caused by bacteria forming an abscess. Ulcers are local defects caused by the physical sloughing of inflamed necrotic tissue on mucosal or skin surfaces.
The local response also triggers major systemic reactions. Exogenous pyrogens trigger cytokines, which upregulate prostaglandin E2 in the brain's hypothalamus, resetting the body's temperature higher to cause a fever. In the liver, interleukin-6 stimulates the mass production of acute phase proteins like C-reactive protein, which act as systemic opsonins. Concurrently, in the bone marrow, colony-stimulating factors accelerate neutrophil release, causing a significant spike in white blood cells known as leukocytosis.
Ultimately, acute inflammation has three final potential trajectories. Complete resolution occurs when the offending agent is eliminated, debris is cleared, and parenchymal cells regenerate, returning the tissue completely to normal. Healing by fibrosis, or scarring, occurs after substantial tissue destruction, where connective tissue replaces the damaged area, resulting in a loss of function. Finally, Progression to chronic inflammation occurs if the acute response fails to clear the agent, transitioning to an ongoing destructive immune response.
The unified inflammatory cascade relies on every single molecular checkpoint we have covered, from the initial sensor detection to the vascular response, the cellular elimination of the pathogen, and the ultimate chemical switch to resolution. Every step is absolutely vital for survival.